Right. So today, as Dr. Mawela has already introduced me, I'm Masina John, an emergency physician practicing in Lusaka, Zambia. I'll go straight. Today it's a bit of a packed presentation. I'll try to see if I can go quickly on some section and then try to slow down on other sections where I feel we need more emphasis. So that's my presentation outline. Try to give a bit of a disclaimer, and then I'll try to give some objectives. Then I'll try to do into identification of poisonings in general. And then I'm going to talk about common organophosphate presentations to the emergency department. And then I'll try to give general management principles, and then I'll give some specific principles and pearls on that. And then I'll try to stimulate our thinking in terms of the future research on the topic, which I just came across, and maybe we can have a discussion after that. I'll try to see if I can go through this presentation in the next 30, 40 minutes, and then we can have 20 to 25 minutes of discussion at the end of it all. So I do not have any conflict of interest, and I want to declare that most of the photos that I have from the internet, and most of them are not mine, just for learning purposes. And also, what I'm going to present is not representing any organization that I work for or that I've worked for, and neither am I presenting any government at all. So this is purely an academic and a learning session. All right. We are going to try to learn identification of organophosphate compounds, and then we are going to try to see if we can have a brief understanding on the mechanism of action of common organophosphate poisons. And then we're going to have an understanding on the common clinical features of organophosphate. And then we're going to see if we can institute an initial management and then care of the patients with organophosphate in terms of general management and also specific management. And then I'm going to see if we can have also an understanding and identification of common complications of OPP, which we are going to learn. And then I'll also try to see if I can stimulate a bit of our minds in terms of focus and newer treatment modalities, and maybe what is there, what is new about it, and what we can find out. So in terms of the introduction, so organophosphate poisons are really quite common poisons, usually in widespread use, especially throughout the world, mainly in agriculture, as we know. And they are also used in nerve agents in chemical warfare, like the sarin. I think we all know about the London Russian spy that was poisoned with organophosphate. And also some of them are used as therapeutic agents, at ecothiopent, which is being used in treatment of glaucoma. And these can either comprise of an ester, or they can have an amide or a theoderivative of phosphoric acid, and mostly used as pesticides in chemical agriculture. But suffice to say that these are actually one of the commonest poisonings, especially in the developing countries, with I think a case fatality rate of about 10 to 15%, and most of the cases are actually presenting in the developing world. India, South Africa being, I think, the topmost countries with a lot of poisons with organophosphate in most of the emergency departments. And I think everywhere you work in South Africa, you are going to, at one time, if you're working in the emergency department, you're going to encounter patients with organophosphate poisons. So basically, these poisons are classified into three groups. And there are more than 100 organophosphate compounds out there in the market. And the funny part about this is that in some countries, or in most of the countries, especially in most of the developed countries, these organophosphate compounds are not regulated. So they are over-the-counter medication that you can just walk into a pharmacy and buy and use them, because they are widely used in agricultural products. So they can either be classified as very highly toxic, which are the tetrathiols, which are very, very poisonous. And I'm going to show a WHO classification. And these are the ones that are mostly used in agriculture as insecticides. And then the intermediate toxic, which are the crophiols, which are most of the animal insecticides as well, widely used. And then the low toxicity ones, which are mostly used in the households, like field sprays and all the other insecticides that we use in the household use. And this is just to give a WHO classification of toxic substances. If you find a red labeling, these are very toxic substances, and usually it's put on the container where these compounds are being sold. And then, of course, there's another red classification, which is toxic. And then the yellow goes with harmful, but not highly toxic. And then blue is cautious. You have to be cautious with these substances. And then green is no signal word, or they're likely to be present acute hazard in normal use and slightly hazardous. And then, of course, there are some in class 1A, class 1B, class 2, class 3, and class U, which is not really toxic. So you just have to look at the color band, and you also look at the signal words in terms of if they've got a bottle that they've come with. And then in terms of the pharmacokinetics, organophosphates are highly lipid soluble compounds, and these are well absorbed throughout the body tissues, and this what makes them very difficult to manage at some point. And I think I'm going to talk about it when it comes to future treatment modalities like hemodialysis, because of this wide volume of distribution, it becomes very difficult for them to be dialyzed. And they can be absorbed through intact skin, oral mucous membranes, conjunctiva, and GIT, and also respiratory tract. And this could actually be mode of exposure as well. So we really have to be careful that even intact skin, it can go through conjunctiva and the GIT. So GIT in terms of ingestion, respiratory in terms of inhalation, and then also oral mucosa can be due to exposure to these toxic substances. So the highest concentrations are found in the liver and in the kidneys, and they can easily cross the blood-brain barrier, them being lipid soluble. So they are easily going to cross the blood-brain barrier and causing CNS symptoms. And this is actually what leads to them causing most of the symptoms that we see in the CNS, which we are going to talk about. And then their metabolism is in the liver by oxidation, conjugation, and esterase. And esterase hydrolysis, producing a half-life of about minutes to hours. And that's why most of the patients with organophosphate will present within 3 hours of ingestion, or even within 30 minutes of ingesting these toxins. So elimination is mainly through the urine and the bowel and the feces. And this elimination through the urine becomes very important. We are going to talk about colonization of urine when it comes to management of these patients, but usually which has not shown very good efficacy, as we talk about in the research section as well. But all these are things that have been explored before. Okay, so in terms of the mechanism of action, really, we just need to think about the presynaptic axon terminal, and then we need to talk about the muscle fibers as well as the end plates, or the postsynaptic end plates. So what happens is when the action potential is coming through the nerve, it stimulates the end plates, then it causes the release of acetylcholine. And then as soon as the acetylcholine is released, it attaches to the muscle fibers, which causes another action potential, and then it's hydrolyzed by acetylcholine esterase. So what the organophosphate comes to do is they bind on this enzyme, and then they stop the hydrolysis of the acetylcholine, which leads to overstimulation. And this overstimulation leads to cholinergic crisis of acute OPP, which leads to muscle ischemia and reperfusion. and this muscle, and then muscle fiber necrosis, and then necrotizing the end plate myopathy and calcium homeostasis that leads to constant production of persistent acetylcholine in the nerve ending. So that's really what happens. And this is just a schematic drawing of exactly what I've tried to say. So there's actually a lot of stimulation. So the organophosphates are acetylcholine esterase inhibitors, which increases the acetylcholine in the synaptic cleft, which I've talked about, and then the overstimulation of acetyl receptors, leading to causing signs and symptoms of the organophosphate poisoning. And we can just see the schematic here. The organophosphate is killing the acetylcholinesterase enzyme there. And then, of course, this overstimulation leads to muscarinic overstimulation this side. And then there's also a nicotinic overstimulation on the other side. And because there's this overstimulation, there's overwaking. And this, if it is the overwaking in the muscarinic overstimulation, leads to salivation, lacrimation, urination, defecation, and GI clamps and emesis, with a mnemonic of slag. Some people I think are used to dumbbells as well. And then on the nicotinic effects, because of the hyperstimulation of the nicotinic receptors, it leads to mydriasis, tachycardia, muscle weakness, which is a killer one. The twitching, the fasciculations as well, high blood pressure sometimes, and paralysis, which is also another killer one. Okay, so in terms of the symptomatology, I think I've talked about the muscarinic receptor overdrives. I've also talked about the nicotinic receptor overdrives. In terms of the gastrointestine, it will cause urinary incontinence, it will cause blurred vision, due to both either meiosis or mydriasis. It will cause increased lacrimation. It will cause as well nausea, vomiting, increased abdominal cramps, diarrhea, and fecal incontinence. On the CNS, anxiety, restlessness. Sometimes it can cause convulsions. It can lead to tremors, coma, and respiratory depression, which is also another killer. So in terms of the muscarinic, I think the killer, we call them the killer bees. So the bradycardia, the bronchoria, and the bronchospasms. And then in terms of the nicotinic effects, we have weakness as one of the weakness, and the paralysis as one of the killer symptoms. Okay, so when it comes to WHO classification of severity of the disease, it's classified into mild, moderate, and severe. Mild being serum red blood cell cholinesterase activity or levels of 2 to 3 units per liter. These patients are able to walk, they're able to talk. They come in with abdominal pains. Sometimes they can come in with nausea and vomiting. And also they will have headache and salivation and sweating. Whereas in moderate, they've got levels of 0.8 to 2 units per liter. These will also be talking, but cannot walk. They will have fasciculations as present. They will have meiosis and restlessness, and then they will have anxiety as well. Meiosis just pinpoint pupils. And then in terms of the severe disease, they've got levels of less than 0.8 units per liter. They'll come in coma, they'll have convulsions. Sometimes they can have profound bronchial secretions. We actually call it drowning in their own secretions. And so many complications that they may come with. Cardiac complications mostly. These patients will come in common presentation following poisons, hypotension, profound hypotension, with bradycardia. So they've got hypotension with bradycardia. So this is what we call low and slow. So they are slow in terms of the bradycardia, and they are very low in terms of the hypotension. And so them do patients present with tachycardia. Remember, they can also have a tachy because of the nicotinic stimulation overdrive. But most of the time, the nicotinic stimulation usually presents with weakness as opposed to tachycardia and hypertension. So most of the patients, you're going to find that they present with weakness and a profound hypotension and bradycardia. And some of the cardiac manifestations are actually one of the serious complications, and these are the ones that actually lead to fatality if not treated in time. ECG features are very, really, anything is possible, but usually they present with a prolonged QTC interval. they might present with elevations of ST segments. They might have inverted T waves and a prolonged PR interval. And usually, this patient might actually present with an AF, with fibrillation, arterial fibrillations as well. Very common, and they may have rhythm abnormalities as well, like I said, a fibrillation, a ventricular tachy, sinus bradycardia, like we've mentioned, and usually they might have ventricular extrasystoles as well. So it's very important to do an ECG in this patient so that you can have some ideas. And then the gentleman called Ludomirsky and his team also described the cardiac toxicity following opioid overdose in 3 phases. And there's a phase 1, which is a brief period of increased sympathetic tone, and I think this is due to nicotinic overstimulation. And then this is followed by a phase 2, which is a prolonged period of parasympathetic activity, which includes AV nodal blockade, and this is the one that comes in with a bradycardia. And then there's a phase 3, which is a QT prolongation, followed by episode, which is a ventricular tachycardia and ventricular fibrillation. So these are the 3 stages. And usually what causes this is just basically the direct toxicity to the myocardium, the electrolyte imbalances that the organophosphate produces, or sometimes it might be due to the hypoxia. So once you correct all these 3 that we've talked about, it might actually reverse these cardiac complications. Okay, in terms of the respiratory manifestations, usually these patients will come in respiratory failure, which include the bronchoria, rhinorrhea, and bronchospasms and laryngospasms. I think the killers here are bronchoria and the bronchospasms, because basically these patients are drowning in their own secretions. They will have wet chest, and they will have hypoxia that will lead to all the other complications. So this is and this is mostly due to the muscarinic receptors that are stimulated. So the integrity of the airway may be compromised by excessive secretions, like I've said. The nicotinic effects will lead to weaknesses, which subsequently paralyzes the respiratory and the oropharyngeal muscles. That might actually be a high risk for aspiration, as well as airway obstruction. And then the central neurological depression may also lead to respiratory arrest, which is very, very fatal to the patients. And then in terms of the neurological manifestations, there are 3 different types of paralysis that are recognized in these patients. There's a type 1 paralysis or acute paralysis, which is usually the acute phase. And then there's a type 2 paralysis of the intermediate syndrome, which I'm going to talk about very shortly. And then there's a type 3 paralysis of organophosphate-induced delayed neuropathy. This, I think I'm going to take time to talk about it as well, because it's a common complications that we see in these patients, especially 2 to 3 weeks after they've been treated with organophosphate. Some people have also postulated that these patients actually have a higher chances of presenting with long-term cardiac manifestations like myocardial infarction later on in life, but that has not yet been proven evidence. So type 1 paralysis or acute paralysis is usually seen during the initial cholinergic phase. And this is due to muscarinic effects on nicotinic receptor occupied by the acetylcholine, leading to persistent depolarization of the muscular junction. And here the clinical features include muscle fasciculations, cramps, twitching, and profound weakness. And this is classical of how the patients will present within 1 hour to 3 hours of ingestion of these organophosphate. They'll present with a type 1 paralysis or acute paralysis. So patients may actually require ventilator support because the respiratory muscles are so weak. And because of the respiratory depression, they might actually have a respiratory arrest. And then type 2 usually occurs between 24 to 96 hours after the ingestion of organophosphate poisoning. The patient has been okay, they are in the ward, admitted, and then later on, they just start developing what we call intermediate syndrome. And this starts with ocular muscles, then it goes to neck muscles, then proximal muscles and respiratory muscles, which is the intercostal and the diaphragm. And this happens usually on the course of 24 hours. its onset might be rapid and approximately affects 10 to 40% of patients who have been treated with organophosphate. And this actually develops 96 hours. That's like 4 days after the patient has been admitted. So never in the emergency department. So usually what we see in the emergency department is the type 1 paralysis or the acute paralysis. This is usually seen in the ward when the patients have already been admitted. And the manifestation is that it doesn't affect the conscious level of the patient. So the patient will be conscious, you know, and there will be no fasciculations. There will be no acute paralysis that we see in the emergency department, but it is marked by marked weakness of the neck muscles. So you tell this patient to lift their head above the pillow and they fail to do that. And it is in varying degrees of proximal limbs, flexion, and consistent clinical features. So the respiratory insufficiency is common and frequently draws medical attention to the onset of the syndrome. So once you see these patients are not breathing very well, their respiratory rate is going down, their negative inspiratory force is going down if they are on a ventilator, then you know that this patient might need to be ventilated for a longer period of time. Other possible manifestations are involved in the muscles of innervation by the motor cranial nerves, and also decreased tendon reflexes, especially the deep tendons. But suffice to say that the sensory mechanisms of the skin, the muscles is intact. There's no clinical it's not a clinical manifestation of the intermediate syndrome. This is different from what we're going to talk about, which is the organophosphate-induced delayed neuropathy, which is a type 3. Okay, so this one usually presents between 2 to 4 weeks, and this one affects actually the sensation as well, like I've said, which leads to neuropathies present as weakness and ataxia. Initial stimulation causes excitatory fasciculations and then progresses to inhibitory paralysis, and often preceded by back calf muscle pain. So when they step, they feel the pain, and then it also follows paresthesia of the distal parts of the limbs. So here the paralysis is affected, whereas in the first one, the paralysis is the sensation is not affected. So that can be used as a differentiation between the two syndromes. And then the delayed CNS signs include tremor, anxiety, and coma. But remember, in the other one, there was no effect in terms of the conscious level. All right, maybe Dr. Mawela, I can pause for 2 minutes if there are any burning questions before I can go to management. Over to you,
No.
Dr.
I
Mawela.
think you are covering. We are listening, and I think you are covering a very important topic. Maybe the key question, because you see, you have shown how patients usually present. What happens in the next 24 to 96 hours, then you've got 2 to 4 weeks. Obviously, the clinicians are asking themselves, so, you know, when is the right time to discharge such a patient? I guess that is still coming, you know, ahead. Because it seems like even when you think you are winning, these things can still complicate. You know, but what are the implications of this type 3 paralysis, Doc?
Absolutely. So I'm going to try to see if I can give the management to this, but most of this, I think the management is asymptomatic. I'll try to see. There's a few studies that have shown that steroids are actually okay in the OPIDP. So introduction of the steroids to these patients can be helpful. But I think what is important is just to understand the presentation of the patient to start with, treat them aggressively when they come. And sometimes the aggressive management in the emergency department and in the first 3 days can actually avoid some of these complications. All right.
Yeah,
If there are no
before you continue, colleagues on the chat, they are saying no, they are following. I see Michael Teko and Theodora Ukpai, they are saying no, they are with you, they are following. So yeah, I think you can continue, and then we will see as you continue where we can pause again and engage. Thanks.
Absolutely, that's perfect. So I think now let's go to the meat of this presentation. I think what we've been presenting is just basically the actual things that we know, the presentation and all the other complications. And I think why we are here is to share and discuss on the management of the patient, because this is what actually makes things even more interesting. So I think the first thing that we should do in terms of management of this patient is just to see if we have to identify the poisons to start with. So if there are signs of cholinergic excess or developing intermediate syndrome organophosphate, and there's a disparity between the history and the clinical presentation, please follow your clinical judgment. So your signs and symptoms is what is really, really important. Your history, your signs and symptoms become very, very important. And this is where you ask about any bottles lying around where the patient was found. Has there been any history of violence at home? Has there been any history of misunderstanding at home? And after identification, and you have to classify these as organophosphorus or non-organophosphorus, and then you have to treat this patient according to what you find. So really, diagnosis is based on clinical presentation, history, and examination of this patient. Of course, there are other investigations that you're going to do in terms of the serum pseudocholinesterase levels, the serum or the red blood cell cholinesterase levels, which usually will come 3-4 days later. So I think your history and the examination of these patients as they present is what is really going to give you the definitive diagnosis. So the diagnosis of organophosphate is based on history of exposure to the OP compounds. And sometimes it's not just about accidental ingestion of the organophosphate. Sometimes it could be just domestic exposure. It could also be, we call it occupational exposure, like patients that are working in the farm. They will tell you, today we were spraying in the farm and this is how I got exposed, even on intact skin, like we saw on mucous membrane, or by ingestion, especially in children where they will ingest accidentally. And then, of course, a garlic-like smell is an added clinical sign, which is especially in patients that have ingested sulfur-containing organophosphate compounds. This will just give it away as they come in. And this may be aided by insisting the patient attendant to search for a possible poison container in the vicinity of the patient where the patient was being picked up. And this is what I talked about. And then, of course, cholinesterase levels or estimation of plasma cholinesterase and red cell cholinesterase is also very, very important. But these laboratory confirmatory tests will come maybe 3-4 days later after the patient is already in the hospital. So it's very important that you make a diagnosis based on your clinical judgment. And then you, of course, you have to clinically grade this the presentation. Mild is between 20 to 50% enzyme activity that is in the lab, and then also 10 to 20 enzyme activity is moderate, and then severe, anything less than 10% enzyme activity on the lab measurement is really a severe. And then there are two types of cholinesterases. Like I said, there's one which is the serum, and then there's the other one, which is the red cell. So one correlates very well with a clinical manifestation, which is actually the red cell, as opposed to the serum. And this is the one that is difficult to. This is the one that is difficult to find the activity. Most of the labs don't do it. And then the other one, the activity is less, and it's the one. So the red cell cholinesterase is difficult to assay, but it correlates very well with neurological activity in terms of the weakness and all that. So any activity less than 30% is normal muscle function, but any activity less than 10% is gross derangement. Whereas the plasma chorinesterase is easily assayed, but it's very difficult to correlate with the neurological activity. So if you're asking for chorinesterase levels in your hospitals, you have to ask for both, because one correlates very well with the clinical manifestation, the other one does not correlate very well with clinical manifestation. But usually they will give you the plasma one, which is easy to assay, as opposed to the red cell that is difficult to assay. And I think the red cell chorinesterase activities are usually expensive as opposed to the plasma one. So they usually delay giving you these results. Okay, so in terms of management principles, this is where now it becomes very interesting. Remember our previous talk? So we talked about first you resuscitate this patient, which is initial stabilization. You have to look at the risk assessment. We talked about it. What agent, who is taking it? Are they pregnant? Are they children? Are they adults? Are they alcoholics? What are their nutritional status as well? The risk could be different according to the class of these patients. And then investigations, we talked about the ECG, the chest X-ray, and also doing the paracetamol level. That becomes very important in the holistic management of these patients. Remember, if they're suicide patients, they'll probably won't only take one substance. They'll probably want to take more substances. And then supportive management becomes very, very important. And I think I'm going to talk about it as we go down. I'm going to talk about decontamination as well in more details, what works, what doesn't work. I'm going to talk about enhanced elimination as well in terms of what works, what doesn't work. And then, of course, in this topic, I think we're going to spend a bit of a chunk of some time in talking about the antidote, which really works very well in these patients. And then I'll talk about the disposition of the patients as well. So in terms of the initial stabilization, you really need to be particular about the airway. It becomes very, very important. Remember, they've got secretions and everything. And then the breathing and the circulation is also very important. Oxygen at first opportunity. There's very little evidence to say atropine should not be given until oxygen is available. That's by Edman and his friends there. But however, in some hospitals where oxygen is not readily available, just please start the atropine as early as possible. And positioning of the patient is very, very important. Left lateral, neck extended with feet slightly up as opposed to the head down, so that you can aid if they start vomiting. This reduces chances of aspiration risks and also keeps the airway patent, and also decrease pyrotic emptying and absorption of the poison. And then also control seizures, because some of these patients might present with seizures. Correct the electrolyte imbalances like we talked about, because this is what leads to cardiac manifestations, and hypoxia, as oxygen we've talked about. Correct the hypoglycemia if there's any, and also another big management principle is correction of the acid-base imbalances. This patient will probably present in huge high anion gap metabolic acidosis, and they'll need fluids to correct that. So in the initial stabilization management, this is what is really important. And then just after the resuscitation and the initial stabilization, and this actually has to go hand in hand. This is the toxin where antidote actually comes way high above in resuscitation, because it's also part of the resuscitation management. Remember, in most of the poisons, we say antidote should go down because some antidotes are not very effective. In this one, we want the antidotes to be high up there. So the specific antidote for muscarinic effects is the atropine. It has no effect on the nicotinic. If the patient is presenting with nicotinic symptoms, it won't be wise to give them the atropine, because you are just overstimulating. They will have tachycardia and everything, which are the side effects of atropine. So atropine is actually targeting the muscarinic effect. It reverses the life-threatening causes, central respiratory depression, the bronchospasms, the excessive bronchial secretions, severe bradycardia, and hypotension. And this is why we're giving, actually the most important reason why we're giving it is just for the bronchospasms and the bronchial secretions, because we want to dry the chest. So the current guidelines recommend the use of incremental doses regimen to attain target endpoints. and followed by setting up of an infusion to maintain these endpoints. So in the initial phases, you have to give a lot amount of atropine, and I think we're going to have a discussion on this. So bolus doses regimen to start with 2 to 5 milligrams atropine every 10 to 15 minutes. I would say 5 to 10 minutes. So you have to constantly review this patient. So you give 2 milligrams of atropine every 5 minutes to check the chest. If the chest is still wet, you double the dose. And then if you started with 2 milligrams, then you go to 4 milligrams, then you go to 8 milligrams, then you go to 16 milligrams, then you go to 32 milligrams until the chest is clear. Okay, and then now you can continuous infusion regimen of 1 milligram per minute until full atropinization can be used in resource poor settings. So if you have very resource poor settings, you can start with 1 milligram every minute until atropinization arises. And this atropinization we're talking about is clearing of the chest, not the dilatation of the pupils. So the target endpoint for atropine therapy is clear chest on auscultation with resolution of bronchoria, absent of wheezes and crepitations. This is what we are following. Yes, systolic blood pressure above 80, dry axilla, dilated pupils, heart rate above 80 per minute is also good. But if the chest is still not clear, you continue your atropinization until you get your full atropinization, which is clear chest on auscultation with resolution of bronchoria, because this is what is going to kill the patient. So the recommended dose is the initial bolus of 2 to 3 milligrams with subsequent doses doubled every 5 minutes. This is what I was talking about. If there is no response to repeat same doses until atropinization is achieved. And I think these are the most protocols that we've been using, I think in South Africa, in Zambia as well. We've been advocating for doubling of these doses until atropinization has been reached. But if you are in a poor resource settings where you cannot get this, then you can use the other one where you use 1 milligram per minute until you reach your full atropinization. Okay, so a maintenance dose now is calculated by 20% of the initial atropinization dose per hour for 48 hours and gradually tapering over 5 to 10 days. Sometimes we say up to five days, not really 10 days. So, but you have to continuously monitor for signs of atropine toxicity. And sometimes signs of atropine toxicity can be confusing because these are actually the signs of organophosphate in the CNS. There's agitation, confusion, hyperthermia, urine retention, and severe tachycardia. So you have to look for these. If you start seeing these, but your patient still has a chest which is wet, then you have to think about alternative to atropine. So can persist ischemia even in patients with underlying coronary heart disease. So you have to be careful with patients with old patients coming in with ischemic coronary heart disease, and then they've come in with organophosphate. So your atropine, you really have to tighten your doses there. Then over-atropinization may necessitate discontinuation of atropine infusion followed by frequent observation. Like I said, always go back to your patient, check. Are they confused because of the atropine, or are they confused just because of the organophosphate? And when you settle down, the infusion can be stopped, and then you start back the infusion at 70 to 80% of the previous rate. And then anticholinergic agents like glycopyrrolate, which I'm going to talk about in the next as alternative to atropine. If you cannot continue with atropine, but the patient still needs that muscarinic masking, then you can use glycopyrrolate. It's a bigger molecule. It doesn't cross the blood-brain barrier, so it has no CNS effects, but it will have all the other effects that atropine has in terms of the peripheral. And when atropine is not available, you can go for it. So the dosage is 7.5 milligram of glycopyrrolate and 200 mils of normal saline, and then you start the infusion and you titrate desired effects to dry mucous membranes. So this is really, really important, and I'm sure there will be a lot of talks around here, and I'm happy to clarify most of the things. Okay, let me just go quickly to decontamination. So guidelines, universal precautions are really important. You have to make sure you remove the clothes, you thoroughly irrigate these patients, because remember, you can absorb these through your intact skin. So you have to make sure your PPEs are available, and ocular decontamination water only, so you can wash their eyes or wash your eyes as well if you're exposed. with water. All right, that becomes important. And then gastrointestinal decontamination, no evidence suggests that the patients with pesticide poisoning benefit with activated charcoal. And I've put evidence there from these gentlemen that did a randomized control trial, and they found that there was no evidence of using activated charcoal in patients with organophosphate poisoning. Enhanced elimination in terms of infusion with bicarb to make alkalinization of urine. Also, this was beneficial in dogs, but it never had any sufficient evidence to establish use of soda bic in human organophosphate poisoning. So we stick to the rehydration with plasmalite or baso or Ringer's lactate. If at all we are using all those balanced solutions, if what we have is normal saline, we can use it as long as we understand that the acidosis might persist a longer period of time because of the normal saline that we're using. But it's actually a great solution to use as well. But balanced solutions will be better. So infusion of higher doses of 5 milliequivalent per kilo in 60 minutes, followed by 5 to 6, shown a little bit of effects in the animal studies that were used. And then in terms of supportive management, very, very important, ventilatory support is indicated in these patients. And these are the predictors for need of mechanical ventilation. Delayed in the initiation of specific treatment, especially if you delay your atropine. The patient has come in with low levels of sensorium at the admission. They've got a GCS of 315, that is an indication. Pinpoint and generalized fasciculations might be pointing to more of nicotinic effects with weakness, that they might need ventilatory support at some point. Presence of conversion is also another predictor of ventilation. Presence of respiratory failure at admission and high initial atropine requirement if they require more than 128 milligrams of atropine as a dose for them for full atropinization. That is also an indication that this patient might need ventilatory support at some point because the organophosphate has spread to most of the tissues. And then low of early enteric feeding, there's evidence now to show that those patients that were fed early actually had very good outcomes. So early nutrition support in organophosphate poisoning assumes importance that these patients may require prolonged ventilatory support. So you have to make sure that you plan for them to get early enteral feeding. And then other supportive treatments in terms of therapeutics, ketamine has been said to be very, very good. And I think I'm going to talk about it very soon. And then also tazepam, management of OPI, DN, like I said, standard therapy plus corticosteroids, like I said, when I started talking about organophosphate-induced delayed neuropathy. If you add steroids to their management, they usually do better. Protease inhibitors have an advantage. Antidotes or antioxidants like vitamin E have been beneficial in management of organophosphate patients. But these are like ICU management kind of modalities as opposed to emergency department. But I think I'll talk about some of the emergency department therapeutics. Oxims, they have a very, very debatable use, especially in our settings. One, because they are very expensive. Two, they are not readily available. And then three, they are very specific. They should be started within if started after 48 hours, they should be started within 48 hours of having these patients. And they are usually more effective in certain compounds as opposed to other organophosphate compounds. So they are more effective on diethyl as opposed to dimethyl compounds. And we wouldn't know. And sometimes most of the patients that come in, they've got a combination of both organophosphate and carbamates. So we are not going to know which one they've taken because the clinical symptoms and signs will be the same. So in our settings, usually oximes are not really advocated for because their expense just outweighs their benefits. But if you have them, I think that will be a good way to go. The benzodiazepines, I'll talk about them just now. I'll talk about the organophosphate as well, and I'll talk about clonidine as well. So the roles of the benzodiazepines, very, very important in terms of sedation in ventilated patients. This has become a first-line therapy for control of seizures as opposed to phenytoin because of its membrane stabilizing effects. And usually we see very little seizures in patients that are well oxygenated, like I said, unless they've got somine and tabam as the gas agents that have been used, which usually presents with seizures. And diazepam may reduce neural damage and prevent respiratory failure. And this was more advocated for in animal studies. Its efficacy in humans, we are not very sure. Magnesium sulfate has been talked about of late. And this has become very important because it actually reduces hospitalization stay. It also reduces mortality. It has also benefits in reduction of ventilatory days of ventilation. So we can use magnesium sulfate 4 grams in 500 mils of Ringer's lactate, whichever you are using, and run it over 2 to 4 hours. Sometimes some authors have gone up to like 8 grams in that and run it. So bigger doses. 4 to 8 grams and run it over 2 to 4 hours. That has shown to reduce hospitalization and also reduce mortality and reduce ventilatory days. So make use of it. It blocks calcium channels and reduces acetylcholine release from the presynaptic terminus. Remember, it's the release of the acetylcholine that causes the overstimulation of these nerve endings, and that's why magnesium becomes very important because it blocks that. And also reduces CNS overstimulation from the NMDA receptor activation. So magnesium has really become a mainstay of management of organophosphate, especially for severe organophosphates with ventilatory requirements and stuff and ICU, so you have to give them. Clonidine is a centrally acting alpha-2 adrenergic receptor agonist. Really, it has not shown effects in humans is unknown. But shown benefits in combination with atropine if used in animal studies. So we really don't know what it can do in humans, but you can use this. Okay, so before we can now wrap up and then have the discussion, let me just take the last maybe 2 minutes or so to just talk about the future research. So we are thinking of removal of OPP from the blood, especially by dialysis, hemoperfusion, or hemofiltration. This is limited because we know that the organophosphate have got a very wide range of distribution. The volume of distribution is toward it goes into the lipids and into the tissues, so it becomes very difficult for you to dialyze them. So, but this is still being studied. Hemofiltration offers poison removal, beneficial therapy effects, but not really. And then in military research, aims at injecting cholinesterases after crawling into soldiers before exposure to nerve gas. This is not really practical, again, because we never know when will the patient be exposed to this insecticide. But if it is high risk, especially you are going to war in some places where you know they like to use nerve gas and all that, I think this could be beneficial as well. Then use of recombinant like bacterial phosphodiesterases or hydrolysis to break down organophosphate enzymatically. This is also under future research. And this is like the way we do for digiban, like digoxin toxicity, where we use digiban, where these bacteria just hunt for the digoxin and then they bind it and remove it from the plasma. And this is also another good way. I'm sure researchers are thinking about that as well. We are talking about role of fresh frozen plasma. Current evidence not very strong to support because you might need a lot of plasma for you to achieve the effects. And remember, plasma will also come in with its own complications, lung-induced TRALI, which is the transfusion-related lung injury, and also infection as well. Otherwise, that's it from my side. In summary, organophosphate poisoning, remember, you have to identify the poisoning. You have to know the mechanism of action. You have to know the symptoms in terms of muscarinic symptoms, nicotinic, CNS, and then of course the antidote. The oxims in our practice not really emphasized because expense and also availability, and also not knowing which organophosphate we are dealing with. But otherwise, that's in summary. And thank you so much. And over to you, Dr. Mawela. It's been a long marathon.
Yes, I know you had a lot to cover, Doc. But yeah, it was quite empowering. Maybe you can stop sharing. We want to see you, unless if maybe some of the questions would like you to show some slides, you can always reshare, yeah. So yeah, there's a number of questions and comments, but maybe before that, let me allow people to be able to post what they want to post. I think this is quite empowering. I haven't been in the emergency unit in a while. And as you were teaching, I had flashbacks of some of the cases, that we used to see. Actually, in the early days, it was quite an everyday, really, case scenario, more than a rare feature. But a few things, maybe there's a number of questions, so I'm going to just cluster them and maybe let's go through them. You did mention in your presentation the issue of oxygen and maybe the need to use atropine. Can you clarify that better? Why do we need oxygen? And in resource limiting settings, it seems like we can still do without oxygen in an effort to save the patient. Yeah.
Oh yeah, sure. So I've posted two research papers, the randomized controlled trials on that. So one paper was supporting that atropine should be held on until you can give oxygen to these patients. And then the other paper was supporting to say, no, even without administering, or be sure that you're going to administer oxygen, you can still give the atropine. So all in all, start the atropine as early as possible, whether you have oxygen or not. And then once you have oxygen, continue giving the oxygen. So there were just two conflicting papers, two conflicting evidence, almost saying the same thing. Start the atropine as soon as you have contact with the patient.
All right. And then how much is too much atropine? Because it's a trending question there, because you kept on saying, go up, review after 5 minutes, go up. But the colleagues are saying, so does a patient ever get atropine toxicity, or how do we deal with this? Yeah.
Absolutely. So it's a difficult question. The highest I've ever gone is 128 multiplied by 2. That's 256 milligrams as a bolus dose. So you keep on going. As long as the patient has a wet chest, they have bradycardia, and their blood pressures are still tanking, give the atropine. I don't know if there's a maximum dose. I'll need to consult as well.
What's the worst that can happen?
The worst that can happen is just atropine toxicity, where they will have and you see it as soon as you give the dosage. The heart rate goes above 120, the blood pressures goes above normal, 150 over what, and the patient and the chest is dry. Then you can see, okay, maybe we are overshooting, and that's why you always have to examine the patient before you give the atropine. So examine the patient, look at the blood pressure, look at the heart rate, examine the chest. Are there still crepitations? Are there still, is the chest still weight? Do they need more atropine, or let me give them more time? Sometimes if the chest is still a bit of crepitations, the heart rate is above 120, the blood pressure is okay, hold on to the atropine and give them a bit of time. Maybe they just need an infusion afterwards. But usually most of them will go down by the time you reach 64 milligrams as a bolus dose, 120 milligrams as a bolus dose, the chest will be dry, and you can give them time. You can give them time to reassess the patient. So 5 to 10 minutes, 10 to 15 minutes.
Yeah, I saw a follow-up question. Someone saying, so at some point they are struggling to differentiate whether these signs and symptoms they are seeing are due to the toxicity or the poisoning, because it seems like the poison itself can sometimes give you some tachycardia and some hypertension.
Yes. Which is the nicotinic effects. But remember, this patient came in bradycardia, hypotension, and with a wet chest. And that's why I said atropinization is based on the chest. You have to make sure the chest is clear, the heart rate is above 80, and the blood pressure, the systolic blood pressure is above 80. Then you can stop the bolus infusion. Or you can stop the bolus doses and switch to an infusion of 20% for every hour of the maximum atropinization dose. So I think the secret is examine the patient before you give
especially
the
dose. Chest. I think
that's the
take-home message right there. Now, some of these patients, before they ingest or they expose, they also take a lot of alcohol. So is there a key differentiator, between alcohol toxicity and organophosphate toxicity? Or because someone was saying sometimes they are not sure whether to take it as alcohol toxicity or to even consider atropine, because there's a gray area somewhere there. Yeah.
Yes, but I think, like we said, the clinical judgment will be very, very important. The clinical judgment is very, very important. Examine the patient, marry your clinical examination and the history of the patient. If they've got diarrhea, vomiting, sweating, they've got a smell, and they've got bradycardia, and they've got a wet chest, you rather fall to the side of caution as falling to the side of taking chances, because it might not be alcohol at all.
Yeah. So do we notify, and because you said that some of these tests will only get the results later, and half the time we didn't even do the test, we just relied on clinical presentation. There is a requirement to notify. I don't know what's your experience in that space. Do you notify based on symptoms, or we still have to be in pursuit of a confirmation?
I think it would be important to do both, in pursuit of the confirmation and notify as early as possible.
All right, Doc. And what's the role of ketamine? What effect are we looking for? Because you've mentioned, and just to plaster this, then there was a question of magnesium sulfate, because we've got primary healthcare nurses here. And obviously, Maxsulf is an easily available drug. So one of the comments was, at primary care, should I just start with Maxsulf whilst I'm referring in the meantime, because they might not have atropine and other things? Yeah.
I think atropine will be important. Atropine is the most important. Ketamine will be, we can reserve it, especially for patients that are presenting with nerve gas agent-induced seizures. So if they've come in with organophosphate and sure it's organophosphate and they've got seizures, they will have a protective effect when they get ketamine, because of the NMDR receptors blockade that ketamine has. So for me, at primary level, I think ketamine will be my first, the atropine will be my first, whereas ketamine, I'll reserve it for the guys in the ICU to sort it out.
Primary level, you mean a clinic? I wonder if they do have.
If they do have atropine, I think it will be better. Yeah. Paramedics usually do have atropine, if I'm not mistaken. Yeah, I think it will be better. The earlier we start, the better.
Yeah. And then, is there a role for prophylaxis? So are we able to predict which patient will get type 2 or type 3 paralysis, and sort of maybe provide some prophylaxis, atropine? It's a question, I can't remember who asked this particular question, but I thought it's best to leave it to you.
I think it's a brilliant question. I think it's a brilliant question. And like I said, the correlation between pseudocholinesterase activity and clinical or neurological manifestation is very, very poor, especially for the plasma pseudocholinesterase, but very good with the red cell pseudocholinesterase. Yes. So very tricky question. No, yes or no, and unfortunately, I don't have an answer.
Maybe linked to that question is the issue of discharge, because you also mentioned that the maintenance should be taken for, was it 5 to 10 days? And
Yes.
you've mentioned some of the, what can happen, day 2, day 5. I'm very interested to say, what are the indicators that maybe you may discharge? What would be safe discharge timing? Yeah. What would we look for? Yeah.
Yeah, I think it's all clinical based, and mostly it's respiratory symptoms. If they are able to maintain their respiration, they're able to maintain their mentation, they've got good neurological function, and also the initial presentation. If they came in with mild or moderate symptoms, you will be safe to discharge in earlier as compared to someone that came in obtunded, ventilated, and maybe on a ventilator for the next 4 days. And so that one will obviously predict more clinical costs. And I've seen one question talking about administration of naloxone for respiratory depression. Very tricky. Remember, these are patients that can take multiple poisons. They can take opioids, they can take OPP, they can take, but the respiratory depression secondary to opioid will be totally different from the respiratory depression secondary to organophosphate poisoning. The respiratory depression secondary to opioid overdose will only be presenting with respiratory depression only, no effect on the cardiovascular, no effect on sometimes they might have effect on the CNS, but they won't have any effect on the cardiovascular. So I'll be more skeptical to give naloxone in these patients if I'm sure that it's organophosphate, because I know once I give the atropine, it will reverse.
Yeah, very, very, very interesting. Maybe to build up to that, someone was asking about gastric emptying very early on. I know some of your slides were saying there's no effect, but maybe would you like to talk to that?
Yeah, sure. So patients that present very early, like the ones that are presenting within 1 hour of ingestion of the toxin, it will be very, very important. But make sure you do it safe. You have to intubate this patient, protect their airway, and then you can do the gastric emptying, because the benefits will outweigh the complications if you do it in a patient that you haven't yet protected the airway. They're going to aspirate and you're going to cause more problems. So presentation within 1 hour and doing it safe by protecting the airway before you gastric empty is a good way to go. Effects of activated charcoal, not really found to be beneficial in these patients.
Superb. And then you've mentioned early enteral feeds. How early is early? Is it the same day? Are we looking at certain indicators before we can look into that? Yeah.
Sure. So patients that are intubated, ICU, being managed in ICU, you can feed the same day or the following day. So the earlier you start the feeds, the better the outcome.
And a follow-up question was asking if that would not enhance the absorption of the poison, if maybe it's around the GI lining and so on.
Yes. So actually, the evidence is that once you feed them, it stops the blood from flowing through the heterohepatic circulation. That actually makes it more easier for the absorption of the. It actually stops the toxicity effect of the poison, because remember, it's going to the liver, then it goes to the kidneys for excretion. So by the time it goes to the liver, it produces intermediate that actually causes the problem. So you want to avoid that passage.
Okay, yeah. Before I go again through the Q&A to check, this question is from me now, Dr. Mawela. You've mentioned that if your patient presents mostly with nicotinic symptoms, maybe atropine is not necessarily the best antidote. Do we have an alternate option for that?
So unfortunately, we don't have.
Yes,
So we
yes.
treat symptomatically. So we want to lower down the blood pressure. We want to give them some fluids. We want to, actually, the killer most nicotinic effect is weakness and paralysis.
Yes.
So the best way we do is intubate them, ventilate them, protect the airway for a period of time until the pseudocholinesterase activities have resumed.
Okay, NG tube mandatory for all patients?
Not all patients.
Okay, yeah.
There's never all in emergency medicine or never all in medicine. So if the patient comes in with mild symptoms, they are walking, talking, there's no need for an NG tube. But I think patients that need to be ventilated, intubated, ventilated, they'll probably need to have an NG.
Yeah, and I saw a number of questions talking about muscle relaxants in that context. Colleen and I can't remember what the other guy mentioned. Any issues with muscle relaxants in this context? Thanks.
Absolutely, a good. I was actually waiting for that question.
Because there's Colleen, and I think it was, but anyway, I think it's the same. You can just address, the question. Yeah,
okay.
Sure.
It's a very good question. So I think what is important there again is just to understand the mechanism of action and also to understand the excretion of the muscle relaxant. So if you are going to use scoline to intubate this patient, if scoline is the only thing that you have and you want to intubate this patient, go ahead and use it. Just indicate in the file that I've used scoline. It means this patient will be paralyzed for a longer period of time, so that whoever takes over that patient management, they will know that this paralysis is probably due to scoline effect and because of the effects of the organophosphate on the cholinesterase levels. So meaning the scoline will take a longer period of time. So the patient has to be ventilated for a longer period of time. But otherwise, it's not 100% absolutely contraindicated. So as long as you state that this is what I've used, this is the only thing that I had.
Yeah, I need you to look in the Q&A chat. There's a question by Mauricio Cavallo, 1858. If you can look at it in the meantime, whilst because I think it's important, but I might struggle to. It's at 1858, ne? Mauricio
1858.
Yeah. Yeah.
All right. Regarding RSI for intubating these patients, I know we don't use scoline for these patients in ROS. Okay. What is the recommendation, or is there any better? Is there anything better? Oh, of course. If you have rocronium, you rather go with rocronium, you know. But I've talked about it. If you have scoline and it's the only thing that you have, and you want to do ROS, you want to do RSI for these patients, go ahead and use it, but indicate that have used scoline, and it might take longer. The paralysis might take longer. So meaning the patient might need a longer period of ventilation.
Super.
Sure.
Atropine, do we need to dilute it? Because somebody's asking, which one do we dilute? Do we not dilute? And when? How do you decide? Yeah.
Absolutely, a very good question as well. So the bolus doses, the incremental doses, the 2 milligrams, the 4 milligrams, the 8, 6, or whatever, 16, 32, you don't need to dilute them. But the infusion, you have to dilute it because you are making it as an infusion. So you can put it in 200 mils of normal saline, and then you calculate the infusion 10% and how it will run. But the incremental doses, give them as neat as possible. There's actually evidence to say patients that are in ICU that received a neat infusion of atropine, they actually did better than the ones that received the infusion with dilution. So maybe in a proper ICU setup with good pump systems and good infusion pumps, you rather go with a neat and not the diluted.
Yeah,
but in the emergency department,
also be guided by mild, moderate, or severe, and how bad your patient is, which is quite key. Now, remember, we're giving atropine to reverse the effects, right, including bradycardia and hypotension. So at which point would you consider adrenaline versus just continuing with your atropine scale up? Yeah.
So if the effects are secondary to organophosphate alone, Remember, organophosphate alone.
Mm.
As soon as the chest clears, your bradycardia should have improved. Your hypotension should have improved. But remember, because the organophosphate also have got a direct toxicity effects on the myocardium. So remember, there are three things that are causing the myocardial injury. One, the direct toxicity of the toxins. Two, the hypoxia itself, oxygen.
Hypoxia, yes.
So hypoxia, direct toxicity, and electrolyte imbalances. So what you have to aim for is correct these. Correct the hypoxia, correct the electrolyte imbalances, correct the acid-base abnormalities, and make sure that the hypoxia is sorted out and the chest is clear. Then now you can decide, is it the direct myocardial toxicity, or is this just due to cardiac abnormalities that are causing this hypotension? Then you can wait. But as soon as the chest is clear, then you can decide.
Let's go to 1901. I need you to look at 1901. Then I need you to talk about gastric lavage in early management. But look at 1901 by Ngobeni Mohomozi.
Any relationship between OPP and CPR with no evidence, or CRP with no evidence of pneumonitis. Wow, okay, that's a good one. So CRP as in terms of C-reactive proteins, right? There is some evidence actually that OPP increases C-reactive protein levels. But again, you have to remember that these patients are going to be ventilated for a longer period of time. They're going to be suctioned. They are going to be staying on the ventilator for some time. So you have to watch out for infection, superimposed infection. So I think it will be very important for you to look for that source of infection and then start an antibiotic early. But in the first 2 days of management with a raised CRP, I'll probably take it as its organophosphate effects.
Yeah, Doc, maybe the issue of PHC, let me ask it because I see the nurses want to use Maxaf. Can I ask, because they don't have Atropine, can you then take an approach to talk about pre-hospital care, whether it's from emergency setup or from PHC? I think you have covered it with our risk death, but maybe just emphasize that beyond the drugs, there's immediate things that can be done as part of disposition or referrals and stuff, yeah. Because it seems like the primary healthcare, people want to give something, right? But I think let's just say the principles, you are in a clinic, the patient needs hospital care, what are the top 3-5 things we need to be doing? Yeah.
Okay. I've seen a comment there to say PHC do have atropine. So I think PHC, your best mode of management.
Trolley, before you say it, in the emergency trolley, it's standard
ABC.
that atropine should be there.
ABC.
Yeah.
ABC. Take care of the airway, positioning of the patient, get an IV line, start the fluids, refer the patient. If you have atropine, start atropine.
Yeah. All right.
Simple, easy.
Easy. Okay, the last question, which I see here, Atrovent nebulizer, you didn't mention it in any of your supportive treatment, your beta adrenergic agonists and stuff. I just, because maybe they are hearing the wheezes and the secretions, right? So a wheeze equals to bronchospasm. So, yeah.
Very important question. Very important. And I think there are a few studies that have actually not looked at salbutamol as a bronchodilator, but they have looked at ipratropium bromide. Because ipratropium bromide is a parasympatholytic. So because of the muscarinic and nicotinic effects, which are more of a parasympathetic overstimulation, there is actually small studies that have shown in stable patients that are able to ambulate, that do not have severe symptoms, you can actually give them a nebulizer with ipratropium bromide to cut off that parasympathetic overstimulation. So again, what is important is putting everything into context. They've got vomiting, diarrhea, secretions, and they've got wheezes and wet chest. Sort out the muscarinic effects with atropine before you can consider anything else.
Superb, superb. Dr. John, thank you very much. I think we have went through most of the comments and questions, and if you read carefully on the chat, you will see that the platform is dealing with clinical topics that are important for health workers. You know, scenarios they are going to see tomorrow. We are not influenced by external parties to talk about certain treatments or this or that. And this sort of guides, you know, how we select topics. It was quite empowering. You know, everyone is appreciating your talk. Do you have any closing remarks? I see you're going through the questions. If there's any question you still want to address, but you might as well also put your closing remarks on that. Thanks, Doc.
All right, I've seen something from Jelin, and I think it's very, very important. The issue of notification, and you know, this is really something that we've been advocating for. We've seen a lot of patients with organophosphate. It's more like a pandemic. There are a lot of poisonings and stuff, and I think one of it is poisoning surveillance, which she's talked about as well. He or she has talked about, and further investigation and prevention of further poisoning. This is a very, very brilliant note, and I think we need to take about it. And we need to talk to the community, and we need to talk to the policymakers as well to just intensify this notification. Notification becomes very, very important. Unfortunately, we can't change the rules in terms of procurement of this because they are widely available and widely being used. But I really take note of that note. It's really, really important. That has to be emphasized that we need to take poisoning surveillance. And of course, a word to the poisoning center in countries where they've got very good operating poisoning centers. It's very, very important. If you're not sure about the toxins, please give them a call. They are brilliant people waiting to answer your calls and waiting to give you instructions at all time if you're not very sure. So in closing, wide range of presentation, and wide range of organophosphates. Don't limit yourself, but remember your clinical judgment is very, very important. Your management of the patient depends on your history and examination, and that's really what matters. And yeah, sometimes keep it easy. Sort the airway, sort the breathing, sort the circulation, give the ICU guys to take care of this, the complicated stuff.